Hey everybody, Dr. Bob McNutt here again, talking about a patient's clinical question. My site, YouTube channel, and my website is dedicated to helping patients fully participate in their medical decisions. And all medical decisions require you to make a comparison among alternatives that are options for your care. And the question this week is a fascinating one. We'll take several video blogs to get through it entirely, but I'm going to try and condense it down at least to start. This is a question from a woman with breast cancer. She had an estrogen receptor, progesterone receptor, HER2 negative, stage 1 breast cancer. That means breast cancer was localized to the breast, no nodes involved. She had a mastectomy as her primary treatment. Her physician asked her to consider getting genetic tests on the cancer to determine further therapy. The point was, from the physician's perspective, that she might need an addition to an anti-estrogen, typically tamoxifen. She might need chemotherapy, and that these genetic tests can be used to help that determination. When she heard this, and she heard about the cost, she was concerned, and she gave me a call. And we went over the data. And as always in these video blogs, I try to go over the data first so you get used to seeing the data, and I always present it in the same fashion. If you look above on my website, and I'm going to try to embed it into this video, you'll see that there's a table that is typical of all the analyses that I try to do to present a standard uniform way of looking at information. It consists of 4 columns. Outcomes, clinical outcomes being measured by the clinical studies. The 2 middle columns are the comparators. And in this case, it's tamoxifen alone or tamoxifen plus chemotherapy. And in the last column is a difference. Now I need to set the stage for this table a little bit. Remember, this is a woman who is asking about getting genetic tests to determine therapy. This clinical trial is an example of trying to use that test. So this is how the trial played out. A bunch of women, about 10,000 or so, were given genetic tests. About 17% of them were a low-risk genetic test. And in that group of women, all of them were put on tamoxifen alone and not given any other options. If they were high risk in this test, this genetic test, which I'll talk about in a minute, they were given tamoxifen and chemotherapy with no other options. The entire trial was based on about 70% of the population who had an intermediate test level. Somewhere between 11 and 25, but I'll get to that in a minute. Those women that had this stage 1 cancer, ER/PR positive, were randomized to receive either tamoxifen alone or tamoxifen and chemotherapy. The idea was to see that if in this group, this grouping of genetic tests could show that the outcomes were essentially equivalent whether you got chemotherapy or tamoxifen for this intermediate group, that would be a very important finding, and that you could maybe forego chemotherapy, which is onerous. Well, here's the results of the trial. And this table depicts only the women who had that mid-range genetic test level. You can see that the chance of recurrence at about 10 years on tamoxifen alone was 8%. If you got chemotherapy, the recurrence rate at 10 years was about 7%. Now, these were not statistically significantly different, but they were different by 1%. The second row under there, in terms of outcomes, I looked at the overall survival. And this is a very interesting point for women with breast cancer. The question is, do I need to find it early or can I treat it late? And notice that even though the recurrence rate was a little bit more with the tamoxifen alone in this intermediate group of people, the survival rate of both groups of people, those to tamoxifen only and those who got tamoxifen and chemotherapy, were identical at about 94%. This is good news. That's 10-year survival of 94% is an excellent survival rate. Now, the chemotherapy has toxicity. And while they didn't measure it in this individual trial, there's plenty of studies out there that suggest that chemotherapy has a very high complication rate. And I only picked the most severe complications. Those complications in women stated after the fact that they were so bad that they might forego any further chemotherapy. And that occurred in about 25% of women. So let me summarize in that last column. The differences. This is the differences and the comparisons, the treatments is what's very important. So there's about a 1% difference in the recurrence rate at 10 years, not yearly, at 10 years. And according to the researchers, this meant they were equivalent. But that just means they didn't study it in such a way to tell whether 1% was really better. They call it an equivalent study. So they assume that this is equivalent. And from a survival standpoint, whether you get tamoxifen or chemotherapy in that group with a medium score on this genetic test, your survival's the same. The side effects are pretty onerous, though, about 25%. Now, this woman looked at this table and said, I don't want this genetic test. Doesn't seem to do much. It doesn't seem like I need the test, because it looks to me from there's not much difference from chemotherapy, irrespective of what I get. And therefore, I'm not going to take that genetic test. She said, what do you think? I said, well, like I said, all decisions are yours to make, but it certainly looks like the genetic test doesn't have much of an effect for anybody in this group. Now, I warned her a little bit that the study was an unusual one and that it didn't test any comparators if you were the low genetic test or a high genetic test. They just assigned you those treatments. That means they didn't test whether or not you needed any tamoxifen if you were low group, because you got away with nothing, which would be a very important, and I think one of the remaining last questions that needs to be asked in breast cancer. Is it entirely possible that no treatment is necessary in this group of women with very low genetic tests, or maybe for anyone? On the other hand, in the high-risk score, they didn't give you an option of only taking tamoxifen in this study. You only got chemotherapy. So the only group we can really talk about is that intermediate group. And again, about a 70% chance that you're going to be an intermediate test positive in this genetic test. And there's about a 20% chance you'll be low and about a 15% chance you'll be high. Now, this test is a 21 gene profile. There are other ones out there. There's a 70 gene profile. And the attempt is to, quote unquote, get personalized medicine. Can we develop a genetic profile in such a way of your tumor or of yourself that could help you predict whether or not you'll respond to various treatments? In this study, the outcomes are exceedingly good at 10 years. The overall survival group was about 98% in those that were just getting on tamoxifen and they were at low risk. It's very hard to show an additional benefit of anything, whether it be a test like a genetic test or a treatment, when the survival benefit is really high. It's hard to show that you'll live greater from when you're already going to live about 98% of the time. So this woman did not do the test and decided to just go on tamoxifen. Now, this study I could go in depth about. I thought it was an interesting trial and that they didn't do the comparisons across some of those genetic tests. But this also shows us the importance of doing these kinds of experimental studies. This genetic test that was used in this experiment was evaluated in kind of an inferior study design. Only about 25% of women in one study that had tissues were tested on this genetic test, and it showed that if you were low on this genetic test score, you only had a 7% recurrence rate for distant disease at about 10 years. If you were intermediate, you had about a 15 to 20% chance of recurrence. And if you were high on this genetic score, the score of over 26, you had a 30% recurrence over 10 years. Now, that was a retrospective study of a subsample of a group of people from a trial from 1980. You can see from this trial that the benefit of those categorizations of low, medium, and high aren't nearly that powerful. And in fact, in this trial, there was only a 3% chance of distant recurrence in the low group, a 5% chance in the intermediate group, and only around a 13% chance in the high group. This difference across the test is not nearly as big as it was in the retrospective observational study. This is why experimentation is important. That's why I only presented randomized trials for you to make your decisions. So I hope you find this helpful. This woman said no to genetic testing. Doesn't look like genetic testing has much to offer. The only caveat is they didn't power or didn't do this study to detect whether 1% was real or not in the recurrence rate. That may mean something to some women, but at this point in time, the study isn't strong enough to say for sure it's even 1%. So genetic testing at this time probably not very helpful for women in this group. So I hope this is helpful for you, and I hope that you can use this information with your physician should you face this decision.